66 years ago, Mischa Krebs' grandfather founded a private dental practice in Alzey, where Mischa now works as the third generation of dentists in his family. Here, Mischa spends about 4 days a week treating patients, and the 5th day is reserved for working with students and postgraduates at the Goethe University in Frankfurt.
I think we have wonderful new opportunities in single tooth replacement because we have wonderful new digital techniques. And they give us the chance to get big advantages for dentists as well as for our patients. So they can get fantastic and even better results in a really short time span, and that saves also treatment time for me as a dentist.
Mischa is a family man who enjoys all different kinds of water-related activities. His weekends and summer holidays are preferably spent on board his boat, together with his wife and 3 sons. Today, Mischa will give us his perspective as a surgeon on digital techniques and on planning for implant-supported single-tooth replacements. Ladies and gentlemen, let's welcome Mischa to the stage.
Hello, everybody. It's a great pleasure for me to meet all of you, at least online, as we cannot meet in person. But I have the honor to talk to you about a great news you have in Brazil with a new Simplant system for Ankylos. So actually, this is something we use a lot, and it is really a great tool to improve implant treatment. And I want to share some of my cases and our daily working with this system with you. You all know that we have hard times and the virus dominates the world. I hope you're all sane and no one of you is severely affected by Corona, because this is really something that changed our life and our working as well. You already heard that I'm working part-time in private practice as well as university, and our practice was founded now in the year 2010, 70 years ago. So my grandfather, you see on the picture, founded the office in the year 1950. And actually last year we wanted to celebrate 70 years. This was the 60 years celebration with my 2 sons. Today they're 10 years older. So you imagine they're a bit bigger, but grandfather is not with us anymore. So we cannot celebrate with him anymore. But he gave us a lot and we still work in the same office where he started. So here I have a patient that came to me in the university hospital, and you immediately see that she had a really hard time. What happened? She gave me this picture and told me, I never want to look like this again. So what happened? I asked. Well, she said, I went through a bone grafting and now I have bone and I want implants, but I never want to look like this again. And I mean, it is totally clear why and understandable. It is awful how she looks, and I cannot really imagine how that happened. I never saw someone looking like that after a bone graft, but I totally understand what she wants. And she told me, give me implants, but don't open my gums again. So what we did is we used this great tool. We used the Simplant guide. We placed implants. We immediately reconstructed her with a provisional bridge, you see, and we placed those implants transgingivally without any opening of the gums. And how did she look a week later? She came and gave me a package of painkillers and said, here are my painkillers. I didn't need anyone. I didn't have any pain. So that is what we want to see with our patients. And that is what makes our patients happy. And in the end, makes our offices busy. So how do we plan our implants? What is the standard? Just a panorama? So this is a standard for implant placement in a lot of cases. Just a panorama, just some vertical measurements, but is this really the information we need for implant planning? Actually, it is just 2 dimensions and the third one is missing. So do we have any ideas or hints? In this case, what is the problem with the implant? Actually, it looks quite fine. It has a relatively long crown, but there is nothing wrong with it on the panel. So remember, this is just a part of the real 3-dimensional bone. And in the Cbct scan, we all of a sudden recognize that it's a miracle that this implant is still in. It's just osseointegrated on some parts of the palatal side, and the rest is free in the soft tissue. So only the 3rd dimension gives us a real knowledge about the situation that we have in front of us. Another case, a straightforward case, we thought about 4 implants in lower, Ankylos Syncone immediate reconstruction, bone grafting, sinus lifts both sides in upper, 6 implants, and a reconstruction on top of that. So from this picture, I would say it's quite a straightforward case and you can work in a good way. So the grafting was done. You see the syncones in the lower jaw, and you see that there is a bone graft in the upper. After this, my colleague in the University Hospital, Puya Pavini, did a Cbct to plan an immediate reconstruction. And what did he recognize? Well, from this picture, I would say it's quite all right, a good sinus graft. But what if we look into the third dimension? We see that the patient has a septum that goes along parallel to the buccal and the nasal wall of the sinus floor. And we see that he grafted till the first bone wall that came up, and he thought this is the palatal wall, but it wasn't. So what if he had just placed an implant with a panel? He would have been placing the implant in the sinus without understanding what really happens. It was possible to solve that. Second grafting from the palate, not a big deal, but the knowledge, how it really looks, would have changed the treatment totally. Knowledge is power, and this is what gives us the power to do the right decisions for our patients. If we look at these cases that come to our offices and patients ask, can you repair that? Well, this is not just wrong planning, it's wrong surgery. It is someone placing an implant in an absolutely wrong position. And we cannot correct that. The only possibility is to remove the implant, start with bone grafting, and replace the implant. So it is a nightmare for the patient. Actually, there are quite some complications that we sometimes have to face, but malpositioning is a problem that we cannot solve. There is no solution but taking the implant out. And this is something we can avoid absolutely when we do a perfect planning and place an implant through the guide, which will be in the perfect position. Here you see it again. The planning probably was not too bad, but the surgery is a mess. It will be a problem for the patient, and you cannot do a good reconstruction on top of this wrong surgery. Everything changes and develops just into one direction, the digitization of everything. And that is what we have in our offices as well. And guided surgery gives us a great tool because we can plan the implant according to the bone, the soft tissue, the antagonists, neighboring teeth. So we have everything for the perfect planning of implant, position, and reconstruction. Better than we dreamed of in the past. What we need is 3D data. So we need a Cbct and Cbct data. What we need as well is a surface information of the teeth. So we can either do an impression and a digitization in the lab, or we can do an intraoral scan, use tools like the great Prime scan, which we use for every implant. Every implant prosthetics now is done on base of a scan. We come from impressions, but it is perfect for implants. Here we have a patient, it's Alexander. He lost all his teeth. And we asked him, well, what are your wishes? He had 2 full dentures and he says, I cannot live with them anymore. He said, the key is I want to get rid of the removable. I need fixed teeth. I cannot live with the removable. Give me fixed teeth as soon as ever possible. So we learned patients with removables, they can live with that. We can do graftings, we can take time, and in the end, they will get their implant-borne reconstruction. No, he tells us, give me fixed teeth today if possible. I don't want to wait. I want to laugh and eat, be in social life. It should not be too expensive, but it should last forever. This is the homework that we get by our patients. So we have the lower jaw, how to proceed. What do we have to do step by step to get a reconstruction on base of a guided surgery in this patient? So we want to do a mucosa, a soft tissue supported guide. We have no teeth left and we want to stay minimal invasive, not opening the gums. So what we have is the total denture of the patient. And this is a good setup. So actually this denture was made new. So the teeth are in the right position, in the right vertical dimension. So what we do is we use this as a setup, as an information where the teeth should be, and can then go into the Cbct scan. Well, in these cases, we can easily use the denture as a radiographic stent or guide. What do? We take these little barium sulfate balls that we can get from Dentsply. We make little marks in the resin and just take some glue to place these balls on top of the denture. Then we give this into the patient mouth. Important is that this denture is seating nicely on the soft tissue. If there is air or jiggling, don't use it. In the end, the stent is basing on the design of this denture. So if this denture is jiggling, your stent will be jiggling and have air underneath. It will not work. So make sure to reline it if necessary. Then we go into the Cbct. You see that we do a scan with a patient. We love to give the patient a little jig of silicone. Then we know he's in perfect position and can bite. What we have to do then is we have to do a second scan. So after scanning the patient with the stent, we have to scan the stent without the patient. So a second scan, just the stent without the patient. And then we get DICOM data, so information of bone and the stent, and then information of the stent alone. And then we can go into the software and can start working on that. First step is that the software automatically superimposes. So the software takes the bone, takes the denture, and knows from the balls where these two pictures have to be set together. So these balls are in both pictures, and the software brings them together, superimposes here a picture out of the software, superimposes the picture in the upper. The upper row would be the Cbct of patient with the stent. Second row would be Cbct of the stent alone, and the computer brings both together. What we have then is we have the information of the bone, of the stent, where it is seated, where our teeth should be. We have the setup. And the negative form of the stent will be the soft tissue surface. So we also know soft tissue thicknesses. So we have everything to do the perfect implant planning. We plan our implants, and what we plan in addition is we plan osteosynthesis screws to fix the stent during our drilling. You know, a denture could be slightly moving, and we want to avoid that. We want to have a totally stable stent, so we fix them with osteosynthesis screws, which are planned similar to the implants. The software then calculates out of our implant positioning, out of the osteosynthesis screw position, and the old denture, a design for our guide that we can use with Ankylos. So this is how the guide looks like when you get it and before you start to do a surgery with it. You see there pink, so this is A implants, 3.5 millimeter diameter. You see as well that we have these white, not white, metal shaded areas. This is where we have the osteosynthesis screws. And you see that we have lateral open sleeves in the posterior. This is a great tool unique for Simplant. So if you have a limited mouth opening, you can enter the drill from the side and win the height of the stent till the soft tissue surface. So if there is a limitation in mouth opening, this is a good possibility, and this is something that helps you a lot. So if we have delivered the stent now, we can then start into the surgery and place the implants through the stent and have a happy patient in the end. So how does it look like? Here you see how we enter the stent into the mouth. What we have to do is to fix the guide buccally with the osteosynthesis screws. First, we mark a little bleeding point where we will be with our implants, and then decide, do we have enough of keratinized tissue? Then it's perfect, and we can go on with a soft tissue punch. Do we miss keratinized tissue? Then we should go on with a mini flap. We give the patient back his upper denture. We take the jig that we used during the Cbct, and let the patient close in full occlusion so that he presses down the stent on the soft tissue, that it is firmly in place. You see it's slightly pale beneath the stent, and then we can start to prepare for the osteosynthesis screws. So what we take is a drill. We just have planned the length of these osteosynthesis screws. Drill goes down full length. We insert the screw, and then one by one, after 3 screws, we have fixed the stent firmly in place so that we can go on with implant positioning. You see that it is slightly pale, huh? How it is firmly seated. After placing this, we can then start into implant positioning. For that, we remove the upper denture. It's easier, we have more space. Here you see the soft tissue punch. So the first step would be punching the soft tissue. Then we have a second drill. Second drill is the initial drill. It marks a 2 millimeter hole for the 2 millimeter pilot drilling, and it takes away the soft tissue so that we don't have to remove the stent. We can leave it in. We just go drill by drill. You see you have a physical depth stop, so you cannot drill too deep. And then we can go to the next drilling. Here you see for the first time the sleeve on drill. So this is this little piece. It is moving on the drill and is guiding the drill while going down. And this helps us. Here you see how you can insert it a bit more easily. And this helps us to drill for the implant without having an additional drill key or adapter or something. So you have just this sleeve on drill, and this makes it easy. What we also have, you see it here, internal and external irrigation. But we would suggest to just use internal irrigation. In the past, we used external as well, but imagine how much of the water that is coming out there will reach the tip of the drill. So this is why we use internal irrigation only. There is more pressure on the internal irrigation, more water coming down. And if the water comes up out of the contra angle, then you see it is bulked with bone on the tip, and then you should remove that and clean it. Second step after the pilot drilling, the 2 millimeter drill, we all know from our standard procedure, is the tree spade drill. So for an A implant, that would be the last parallel walled drill. For a B, we would then step to the B drill. After the drilling, we then have, as usual with Ankylos, the conical reamer. And the conical reamer we use in hard bone, just clockwise. In soft bone, here you see it counterclockwise. You have 2 conical reamers, one for 8 and 9.5 millimeter, one for 11 and 14 millimeter. So this is perfect and easy in handling. And we have the screw tab. Pay attention, the screw tab has no physical depth stop. It has just an optical depth stop so that it cannot get stuck and be a problem. So when the surface of the screw tab is flush with the surface of the stent, we are in the right depth and we should not go deeper in screw tapping. Depends on, in upper jaw, soft bone qualities, you don't need to screw tap. It's just necessary in hard bone. It can happen that you need it in upper, but most of the cases you need it in lower jaw. After screw tapping, we then can go and insert the implants. The implants will also be inserted through the guide. So it's a full guided system. But similar to the screw tab, we have just an optical depth stop and no physical depth stop. So when the surface of the instrument is flush with the surface of the stent, we achieved the depth that we pre-planned in the software. As we have Ankylos, we can work non-indexed. That makes it easier if we prepare dentures or something like that. If we want to work indexed, we can also visualize the index with these markings on the implant carrier that you see, these little dots. Here we have the surgical tray, and you see it is very easy, straightforward, not too many drills. It's really, if you're used to place Ankylos implants, this will be totally easy for you. You just have additional, remember, the soft tissue punch and the initial drill. Then you have end length drills. So you have an 8, 9.5, 11, and 14 millimeter drill. You just go all the way down with a sleeve-on drill. The same with a tree spade drill in A and B. Then you have the Conical Reamer, 2, 1 for 8 and 9.5, 1 for 11 and 14. It's all the way down the row. And then on the left-hand block, you have the screw tabs, and on the top, the tools to insert the implants. So it's very clear and easy. Here again, you see the sleeve-on drill, initial position and final depth. This is really a great invention. In this case, what happened after implant placement? So we reconstructed him on base of the SmartFix system. So balance-based narrow abutments in the anterior, SmartFix angulated abutments in the posterior. We take these little silicon pieces from the Syncon system just to make sure that there is nothing that can go into undercuts, so that we can easily remove that and clean up, make it dry, place the denture inside and fill up with a pink composite, and then reduce a little bit the volume of the denture, and the patient has a very nice screw retained provisional bridge. Here you see the pink composite just filled around the hollow cylinders, and patient closes either in full occlusion, or remember here we had a stent that we used already for the X-ray and initially for the surgery. And after the seating of the composite, we can just remove the bridge, make it a bit smaller, and the patient can go home with this former denture as a bridge. Here we have the X-ray, nicely positioned implants, 4 implants for a kind of all-on-4 reconstruction, but we have a lot of bone posteriorly, so we do a bridge till in the back. That's how it looks after the healing period. You see really nicely healed, you see the abutments, and that is the final reconstruction. And final reconstruction is metal reinforced with denture teeth. So remember, it should be affordable, not too expensive for the patient, and this is a nice, stable, long-term reconstruction. And then if we have that, we just need to seat it, check the occlusion, check statics and dynamics, close the screw holes. In this video, we did it with Waxum, and that's the university style. In my office, I do plumber's tape, much easier to replace a standard. Also nice to close endo teeth, so that's a really nice tool. You can sterilize the plumber's tape in little pieces, works great. And then we close the holes with composite. Just check after light curing if it is in the occlusal part, that there is nothing interfering with what we had checked before. And then we're all done. And we have a happy patient. And that's the most important thing. In which cases do we do guided surgery? Well, here we did pre-plan the implant position in relation to the desired reconstruction. And if we do so, we get predictable functional and aesthetical success. We can prefabricate restorations that we use for immediate loading. Remember, if you work with a edentulous jaw and want to do a soft tissue supported guide, you need 2 scans. 1 scan of patient with guide, 2nd scan of just the guide so that the software can match it, and you need these barium sulfate balls. The good about the Simplant software and the Simplant drill system is that we have internal irrigation with Ankylos. That's really great. We have this sleeve-on drill moving, and we have a lateral access for molars. This is really key features that you cannot see in any other system. SmartFix, as we just saw, is something that we don't use for patients who have a too high loss of vertical dimension. They cannot really clean. Aesthetics can be difficult if we have a lip that is not long enough. We can easily parallelize the abutments. They can be turned 360 degrees, so that is great. We have abutments thinner than the drill, so we don't need extra drills to take away any bone in the posterior area. But you have to pay attention. There are undercuts if you have angulated abutments. So make sure that there is no resin beneath this and that there is no problem with these undercuts. If you have resin there, it's hard to remove the denture. This is the protocol. You do a setup, Cbct, DICOM data, matching, implant planning, drilling, and happy patient. Another patient, another guide. This is Jacob. Jacob is a cleft patient. You see that immediately, and we see that if we look into his mouth, and that is why he has big problems and the total denture does not work. It's always jiggling, and this is why we decided here not to go for a soft tissue supported stent. And as he has no teeth left, we cannot go for a tooth supported. So here we went for a bone supported stent. Bone supported means we use the information out of the Cbct and the stent. Here you see two stents because there's the cleft in between, are fabricated seating directly on the bone. And the fit of these guides is great. It's really great. The only problem that we have is we have to do bigger flaps and to open wider. And if we want to stay minimal invasive, we tend to do more soft tissue supported guides. But in this case, I told you why we decided for a bone supported guide. We planned 6 implants in upper. You see 3 8mm, 1 9.5, 2 11 millimeters. See, there was not a lot of bone, but we used all the bone we had. In this case, we prefabricated a master cast, and the lab has chosen the synchron abutments, orientated them in the right way, prefabricated a little key for us. And the great thing is that this is so precise that we easily could transfer the position in the mouth, place some synchron caps on top, glue it in the denture, and the patient was reconstructed as we wanted, and we perfectly used the bone that was there. This is how it looked after the healing. We usually then change to a reconstruction with a metal reinforcement. So we do an impression, leave the abutments in, just place new copings, take a pickup impression, and fabricate a new denture. So what we did here is a digital planning of the implant position, a centrally fabricated master cast. We used a double crown system, the synchron system, and changed the total denture in a double crown retained denture for the healing period. For a bone supported guide, we just need Cbct data and can plan the implant. We don't need any matching. So what did we do here? Why did we use guided surgery? Well, we prefabricated restoration for immediate loading. We pre-positioned the synchron abutments so that we can easily transfer them in the mouth. We used the bone that the patient had, and we avoided additional augmentation. Another case are lingual undercuts. If we have patients with lingual undercuts and we can feel that already, then we do 3D imaging to make sure that there is no lingual perforation. Here you see an implant that got lost in a lingual perforation, and that is something you can really easily avoid if you do 3D imaging. So if you have lingual undercuts, you can really minimize the risk of injuries, and that is something when we really do 3D imaging and a guide. Here we have a single tooth case, Peter, and you see there is the sinus. So if we place an implant, we discussed with him, either let's do a guided surgery or let's do an bone grafting, a sinus lift. So we decided for guided surgery, what do we need here? To fabricate a guide, we need the information out of the Cbct, and we can take an impression, make a lab scan, and the lab gives us an STL data set, which we can match, superimpose in the software, and then we have, again, the perfect information. We know where the teeth are, neighboring teeth, soft tissue thickness, and we can even make a walks up and have the perfect planning. Here you see our implant planning, and you see we are very close to the sinus. We don't want to touch the root of the tooth. And you see, we already planted an abutment as well. And you see that we insert the implant through the guide, similar to the full arch case. It's just the same. We just screw it down, and if the instrument is flush with the surface of the guide, then we see that we've reached the final depth and the implant is in position. I skipped the drilling here because we have not that much time, but you saw that already, and you will see that if you do the same type of reconstructions in your office. And we perfectly placed the implant beside the sinus. There is no opening of the sinus. It worked out absolutely fine. So if we want to do a tooth-supported guide, we need to match a surface information, a lab scan with a Cbct. What else can we do? We can also use an intraoral scan, and we will see that. In which cases do we do guided surgery? Here for perfect positioning of the implant, but main reason to avoid the sinus graft. Here we have a deep fractured tooth, and we discussed about an implant placement in this patient. So what we did, besides the Cbct, we used the fabulous prime scan. So very fast, easy and convenient. We achieve really good data set of the patient. You see, this is really convenient, and that is what we do also when we reconstruct our implants. Here you see the data set out of a prime scan. This is reduced to STL data, and this one is then imported and combined with the cone beam, so matched similar to the lab scan that we had before. You see that there is not a lot of bone, but we get perfect primary stability if we are able to place the implant exactly in this position. If our drill follows the path of the root of the tooth, we will never achieve primary stability and perforate the sinus floor. So in these cases, it's so great to work with a guide. Here you see the guide placing the implant. Here you see we adjusted also the orientation, the index of the implant. Implant is in perfect position. We achieve nearly 50 Newton centimeters in this tiny little bit of bone. We have an implant in perfect position, fill it up with a bone substitute material, place an abutment, a provisional crown, and can immediately reconstruct our patient. You see, this is how it ends up with a great crown, and after 6 months, 2 years, no bone loss, and a perfect crown, no loss of the horizontal dimension of the ridge. 3 years later, we have a really great case, and the patient is absolutely happy. So besides of matching a lab scan, we can also match an intraoral scan with a Cbct to get all the information we need for a tooth-supported guide. In this case, we use the guide to have a rigid guidance of the drill in an extraction socket to be safe that we can place the implant in this position and predictably load these implants. So the workflow is always the same. We have the patient, we need an information how and where the teeth should be, a setup, a walks up. We need a Cbct scan, we get DICOM data, we need to match. Only if we do a bone-supported guide, then matching is not necessary. We plan our implant, we use the guide, and we end up with a happy patient. For mucosa-supported guides, we use the double scan. First scan, patient with stent. Second scan, just the stent, and then automatic matching in the software. For bone-supported guides, as I just said, you just need the Cbct. We prefabricate restorations, we avoid graftings, we avoid problems with lingual undercuts and predictable implant placement in extraction sockets. These are reasons for guided surgery. If you do Cbcts, pay attention, try to reduce the volume and use as small volume as ever possible. If you have young patients, think twice whether you do a Cbct or not. The elder the patients, the less the risk of radiation. Pay attention after extractions. If you do a CBCT and the extraction is not long ago, there are parts of the bone which are not mineralized and may not be visible on the CBCT, meaning you have more bone than you expect. Security distance on the apex of a guided surgery should be 2 millimeters. So in between the apex of the implant, the lingual or buccal border, or the nerve, you should have 2 millimeters security distance that nothing can happen. If you have a questionable position that you cannot really see on an intraoral periapical or a panorama, do a small volume low dose CBCT to make sure that the implant is in the perfect position. You know, my last name is Krebs, and that is a crab. And actually, I'm that little crab. And one crab alone is always in danger. But a big group of crabs can even take the last feather of the bird. So I'm here talking to you, but I'm just a part of groups. And we need strong groups to be able to do cases like that. We have the group in Frankfurt University with Paul Weiger, you see on the left hand. We have all the assistants and colleagues working in the private offices with us. On the top right, some older pictures of assistants in the university hospital. On the lower row, you see the people who make the teeth that you just saw in the lecture, the dental technicians producing all that what our patients see. And on the lower right, you see my family. Usually they're lacking when I'm traveling, but today I don't have to travel and I cannot travel. So actually they're waiting for me and they're happy when I'm back. So thank you, everybody. It was a great pleasure to be in contact with you. You have a great new option in Brazil. Use it. Simplant and guided surgery is a fabulous tool that we use nearly every day in our office. It makes our life in surgery easier. It makes our patients happy. And I think, and I'm sure it is a great option for you in your office. So I'm keen on having feedback from Brazil, how many people use this new tool and enjoy it.